Hello, greetings to everybody who's viewing the presentation. My name is Mehakpreet Kaur and I'm a student of Seneca College from the Coronary Care Nursing program, and I'm here to present my presentation on beta blockers. So let's start away with the presentation. So beta blockers, also known as the beta adrenergic blockers, these are the drugs that oppose the action of the beta-mediated effects of the sympathetic nervous systems. The neurotransmitter epinephrine and norepinephrine that is released by the sympathetic nervous system comes and occupies the spaces on the beta receptors and cause various effects on various target organs in the body. So the beta antagonists are basically drugs that are used to block the excitatory effect of these catecholamines like epinephrine and non-epinephrine. So there are three types of beta adrenergic receptors in various parts of our body. So the beta 1 is in the heart and the kidneys, particularly found in the heart tissue. Then the beta 2, they are present in the lungs, they're in the vascular smooth muscle and the skeletal muscle and in the bronchial smooth muscle of the lungs. And the third is the beta 3 receptors that are found in the adipose tissue and the bladder. So the beta blockers, they are used to block the effects on these various receptors caused by catecholamines of the autonomous nervous system, particularly the sympathetic nervous system. Okay, so coming to the pharmacodynamics of the beta blockers, or first of all, we will simultaneously review the effects of the catecholamines on beta receptors and also the pharmacodynamics of the beta blockers. So here, as we can see, first of all, we have beta 1 receptors as mentioned, particularly in the heart tissue. So when the epinephrine, the catecholamine epinephrine comes and sets on the beta 1 receptors in the heart, so these are the particular effects that it produces. It increases the heart rate and increases the blood pressure. It has a positive inotropic effect, that is, it improves the conduction or fastens the conduction in the heart's electrical conduction system, and has a positive chronotropic effect, that is, it increases the heart rate. So as the heart rate increases, the workload on the heart increases, so of course the oxygen consumption increases. So when these receptors are not activated, or when beta blockers come and occupy the space that was built for the epinephrine, so what effect it produces, it decreases the heart rate, simultaneously decreases the BP by decreasing the cardiac output, that is, decreasing the heart rate, decreasing the stroke value, and so on. Then, of course, it increases the left ventricular filling times because the heart rate is slowed. Preload is increased because filling is increased. Then coming to the beta 2 receptors. The beta 2 receptors are So the beta 2 receptors are particularly found in the lungs, basically in the bronchial smooth muscle. So when the beta 2 receptors are activated by epinephrine, so they cause bronchodilation, alveolar fluid clearances increase. When these beta 2 receptors are not activated or occupied by beta blockers, so what the effect it produces is bronchoconstriction, and same as in the beta 3 receptors, when they are not occupied by the beta receptors, the adenolysis is not produced. So these effects take place almost a lot of times in the day, during the day, depending upon the environment, the circumstances we are in. But when we are in a state of critical illness, these effects can be calculated in the harmful effects that they cause. So the things they cause, like is tachycardia, arrhythmias, cardiac events like of course arrhythmias and myocardial infarction, angina is increased. So catecholamine effect, another is for the beta-1 receptors, is they also increase the renin, which activates the renin-angiotensin system, and H2O reabsorption is increased, which increases the blood pressure. Okay, moving on. So the pharmacodynamics of beta blockers is they are usually taken orally, but they can be given IV during emergency situations. So when taken orally, they are absorbed in the bloodstream through the digestive system. Their distribution is once they're distributed, once they are absorbed, they are distributed through the bloodstream to various target organs like the heart, kidneys, lungs, and they go and act on the beta receptors. That is, block the site of the catecholamines like epinephrine. And the metabolism is they are metabolized in the liver, and they are excreted through the urine. So coming to the classification, there are 3 types. So also there are 3 generations of beta blockers, but we are going to classify the beta blockers based on their selectivity. So there are 3 types. One is non-selective, second is cardioselective, and third is they are not cardioselective, but they have an additional property that they also block alpha-1 receptors. So in the non-selective, so the first one is non-selective. In the non-selective, they block both the beta-1 and the beta-2 adrenergic receptors, that they block the receptors in the heart as well as the lungs. So the examples can be propranolol, nadolol, timolol. Timolol is a type of topical beta blocker. Coming to the cardioselective ones, they only block the beta-1 receptors, that is the receptors that are present in the heart, and block the release of renin from the kidneys. So these are cardioselective. Of course, they act on the heart. So these examples are atenolol, metoprolol, esmolol, and nebivolol. Then coming to the receptors here. Before going to the alpha blocking activity of the receptors, the cardioselectives, although it is mentioned that they only block the sites of beta-1 receptors, but they are not 100% denying of the beta-2 receptors. To some degree, they do block the beta-2 receptors as well. And coming to the third one, with the alpha blocking activity, they block the alpha-1 adrenergic receptors that produce vasoconstriction. So that is, the effect that they produce is also vasodilation. So these examples are carbidiol and labetalol. These are also called the third generation of beta blockers. Moving on. So the indications are varied. Beta blockers have a very vast use, but first coming to the cardiovascular conditions that it is used in. It can be used in chronic stable angina, myocardial infarction, congestive heart failure, aortic dissection, coronary artery disease, hypertension. Although in hypertension, they are used with a combination of other antihypertensive drugs, cardiac arrhythmias, hypertrophic obstructive cardiomyopathy, portal hypertension, and migraines. So there are some uses that are FDA approved, but some uses, like for migraines, they are non-FDA approved. They are given off the label by physicians. Then coming to the other indications, that is outside the cardiac system. These are for the prevention of essential tumors. It can be used in glaucoma, migraine, hypothyroidism, and can also be used to relieve the symptoms of anxiety disorders. So as we know, beta blockers have effect on the heart rate, cardiac output, on the conductivity speed of the heart muscle. So these are used for the heart conditions, and these can be used, and suppose here in glaucoma, it is used to decrease the intraocular pressure. So it can be used in other than the heart too. So now we are going to compare and contrast the rationale for the treatment of different diseases with beta blockers, because since they have variety of uses. So first of all, we'll see beta blockers in angina pectoris. So the only type of angina that we use beta blockers in is the stable or the exertional angina. We do not use it in unstable or presmental angina. So stable or exertional angina is the only angina that we use beta blockers in. So the how the beta blockers work in the angina pectoris, the stable angina, is they decrease the oxygen demand in the myocardium. So what causes angina is that the oxygen supply demand is imbalanced, the supply is less while the demand is more. That causes inguinal pain. So what beta blockers does is they decrease the oxygen demand in the myocardium. How it does that is it produces a negative chronotropic effect, that is, it decreases the heart rate, and it also has a negative inotropic effect, that it decreases the contractility of the heart muscle, the myocardium. It also reduces total peripheral resistance or the afterload, but total peripheral resistance is studies show that total peripheral resistance is reduced with chronic use of beta blockers. So with all these effects, reducing the heart rate, reducing the cardiac output, reducing the workload on the heart, and reducing the strength with which the heart is pumping, it improves the oxygen supply demand balance in the myocardium as the workload with the in the myocardium is decreased. So studies show that with the use of beta blockers for anginal pain, the use of nitroglycerin PNR is greatly reduced. People who have had the first heart attack and has angina with it, it reduces the chances of a second heart attack, and also studies show that it prevents deaths that are related to heart attack. Moving further to the second disease, so beta blockers used in the heart failure. It's particularly in the left ventricular heart failure. So how it works is it improves the ventricular structure and function and the myocardial efficiency. So it helps to make improvements in the structure of the ventricle that has been the mass of the left ventricular is hypertrophied, so it helps to make improvements in that. It helps the function of or the help in the contractility ability of the left ventricular to push blood into the body. So it does it. So what causes myocardial damage could be acute or chronic causes. Acute causes are usually like myocardial infarction. Chronic causes could be hypertension that has caused the left ventricular structure to hypertrophy. So the myocardial damage is worsened with the increased stimulation of the sympathetic nervous system and renin-angiotensin system. So what it does, it reduces the sympathetic drive of the heart, decreases the heart rate. It inhibits the renin-angiotensin system by decreasing the release of renin. So thereby, and it also improves the contractility by improving the structure and then the function of the myocardium. So one more effect that it increase the myocardial work, that is, it increase the myocardial efficiency, but it does not increase the oxygen demand of it. It keeps a balance between the oxygen and the supply demand. So how beta blockers work in heart failure is they take long studies show that it takes long-term use of the beta blockers, just like it did in the previous disease that was angina pectoris. So with the long-term use, it helps to improve the structure of the ventricular, subsequently improving the function and then the efficiency. So the beta blockers that are FDA approved are metoprolol, carvedilol, and bisoprolol. Bisoprolol has shown significant uh, improvements in the left ventricular function. Coming to another disease, that is hypertension. So beta blockers in hypertension, how the beta blockers work in hypertension is not fully known, but the pharmacodynamic of the beta blockers is that it suppresses the effects of the sympathetic nervous system by blocking the site of catecholamine. So this is possibly the action that beta blockers do in hypertension. This is the believed mechanism of it. So initially what it does, it decreases the cardiac output by decreasing the heart rate, but it increases the total peripheral resistance, like initially when you're acute use of it. But with the chronic use or long-term use, it decreases the cardiac output as well as it decreases the total peripheral resistance. So since the beta blockers are working on the vessels, so the vessels adapt and then then the total peripheral resistance is decreased. Thereby it has a whole body effects, so it decreases the blood pressure. It also decreases the release of renin. But however, studies show that beta blockers are not much effective as used in monotherapy, or they are used as first line of treatment. So they work much better when they're used with other antihypertensive drugs that could be ACE inhibitors, calcium channel blockers. So the American Heart Association and Japanese Society of Hypertension no longer recommend beta blockers as a first line of treatment. The physicians are advised to use other hypertensive drugs that are mentioned here, and then if they're not effective, then beta blocker can be used in a combination therapy. So the FDA approved beta blockers are carvedilol, nebivolol, atenolol, and labetalol. So now focusing on diseases that are not cardiac related. First disease is glaucoma. So beta blockers have shown great effects in the management or the treatment of glaucoma. So how it functions in the management of glaucoma is it inhibits the aqueous humor production. So the aqueous humor the increased in glaucoma, the aqueous humor production in the eyes is increased, which increases the intraocular pressure. So how beta blockers work is they inhibit the aqueous humor production. How they do is that they block the sympathetic nerve endings in ciliary epithelium. So since the sympathetic effects in the ciliary epithelium are blocked, they are reduced. So there is reduced or inhibited aqueous humor production, which ultimately decreases the intraocular pressure. So lesser the aqueous humor production, lower is the intraocular pressure. Earlier it was believed that it affects the humor outflow, or it increases the aqueous humor outflow. But now studies have shown that does not affect how or what amount of the aqueous humor outflows, it inhibits or it affects the production rate of the aqueous humor. So some of the topical beta blockers that are FDA approved are timolol, levobinolol, cartiolol, and betaxolol. Another disease that has a treatment of use in beta blockers is anxiety disorders. This treatment is not FDA approved, but it is given off-label and it has shown to produce effective results. So how the beta blockers work in the management of symptoms of anxiety disorders is that they do not actually cure the anxiety, but it blocks somatic symptoms of the stressors. Like once the stressor comes, then a body goes into flight or fright response and it produces certain symptoms. So it decreases or it blocks the physical symptoms that are produced because of the arrival of the stressor. So it blocks symptoms like tachycardia, palpitations, tremors, sweating, trembling. So when we are in a fight or flight response, the sympathetic nervous system is activated and it produces certain effects like increased heart rate, increased palpitations, sweating, movement of the body parts, tremors or trembling due to the stressors. So beta blockers have proven to block these symptoms. So it blocks the positive feedback loop since these sympathetic somatic symptoms are sympathetic mediated somatic symptoms start. There is a positive feedback loop system that keeps on going and it keeps on increasing the somatic systems, and then there is and while in the mind or the brain there is continuous thoughts that is leading to more and more anxiety. So the beta blockers cannot focus on or cannot work on the thoughts or what is going on in a person's mind, but yes, it can block somatic or the physical symptoms that are produced due to the arrival of the stressor. So these are usually used in performance anxiety, stress-related anxiety, and post-traumatic stress disorders, breaking the positive feedback loop of continuous thought that can lead to more and more anxiety. So these are also, but beta blockers cannot, just like in hypertension, cannot work effectively with just as in monotherapy or used without combinations. So it is suggested that it is used in combination with cognitive and behavior therapy. So as I told earlier that this indication is not FDA approved, so physicians give it off the label. So some of the beta blockers that are used for symptoms of anxiety disorders is propranolol and metoprolol. Moving on. So here we have listed how beta blockers work in different populations. So while beta blockers have a variety of uses and it has great effect in most of the population, it works. The effect of beta blockers is relatively less in Black population and older adults. It is not recommended as first line of treatment in hypertensive, in normotensive or hypertensive patients, but it can be used in hypertensive emergencies, especially in gestational hypertension. That is when a woman is pregnant and is facing a hypertensive emergency. Labetalol can be used, and it has a safe and very effective use in these kind of emergencies. So for people with asthma and COPD, non-selective beta blockers are not suggested because they block the epinephrine effect of bronchodilation, so they can cause severe bronchoconstriction and bronchospasm. So in people with asthma and COPD, only beta-1 blockers are recommended. However, the cardioselective beta blockers can still block some of the beta-2 receptors. So coming to the nurse's role in the action and the response a patient has to beta blockers. So the nurse's role is to first of all check the baseline vitals, including the apical pulse, and close and correct accurate monitoring of the blood pressure, taking the history and physical examination of the patient, especially listening to heart sounds, since we're using beta blockers and they have a huge effect on beta 1, that is the beta 1 receptors present in the heart, and then also checking for the respiration rate and the pattern, since they also attack the beta 2 receptors found in lungs. So how the nurse monitors the action and the response to beta blockers is by monitoring the heart rate, since they decrease the heart rate. So to check for any bradycardia, a nurse has to monitor the heart rate. Blood pressure, nurse must know to hold the drug if the BP is less than 90/60. Must monitor the respiratory rate and patterns, since patients with asthma and COPD can have a great negative effect due to bronchoconstriction. ECG, since uh, even though it is used in the treatment of arrhythmias, it can still cause arrhythmias if the patient goes into bradycardia with use of beta blockers. Sensitivity, a nurse needs to look for any allergy to the beta blocker, look for side effects and adverse effects. Side effects are usually related to the cardiac system, bradycardia, uh, to the respiratory system. It could be bronchoconstriction, patient can be wheezing, or it could be a GI upset and could cause diarrhea. So the nurse must know to monitor for the side effects, monitor the intake output, look for signs of edema. Any new edema must be reported to the healthcare provider. Signs for heart failure, just the best way to monitor for the heart failure is edema, which should be reported. Hypoglycemia, because beta blockers have a masking effect for hypoglycemia, and it also reduces the effectiveness of insulin and other oral hypoglycemic drugs. So it also what effect beta blockers have is that they block gluconeogenesis or glycolysis, so in the liver, so it can cause hypoglycemia. Nurse must know that the patient can experience orthostatic hypotension, so the nurse needs to inform the patient to change position slowly. Also, nurse has to monitor laboratory values, since beta blockers have an effect of increasing the values of triglycerides, blood glucose, since it can cause hypoglycemia. It can mask the effects, the signs of hypoglycemia. Also liver profile, because beta blockers are metabolized in the liver, so nurse has to look for liver enzymes and any signs of hepatotoxicity. So nurse also must know the contraindications of beta blockers. So asthma and COPD, nurse must know that the patient should not be administered with non-selective beta blockers, and if there is a necessity of administering a non-selective beta blocker, nurse must check for the respiration rate or any signs of asthma or exacerbation of COPD. So hypotension, since long-term use decreases BP, decreases heart rate. Sinus bradycardia, beta blockers must not be used. In Raynaud's disease, it can produce exacerbation of Raynaud's disease. So nurse must know all these contraindications and monitor closely. Nurse must also know the drug-to-drug reaction, what drug-to-drug interactions with beta blockers. When administered theophylline with beta blockers, it fails to cause bronchodilation. Nurse must know if the patient has been administered with beta blockers, a non-selective beta blocker, and there has been significant bronchoconstriction. When theophylline is given, it will fail to produce an effect of bronchodilation. So another bronchodilatory drug should be used. Antacids reduce the absorption since they are usually taken orally, so reduced absorption means it will have reduced absorption into the bloodstream and reduced effect into the target organs. So when a patient is on blood thinners, there is much more increased risk of bleeding, like with warfarin or heparin. So nurse must monitor signs of bleeding. It masks the effect of hypoglycemia. It alters the effectiveness of insulin. And when given with diuretics, like in a combination therapy with antihypertensive drugs, it can cause severe hypotensive results. With diuretics, nurse needs to monitor the blood pressure. Sorry. When lidocaine is administered along with beta blockers, it can cause lidocaine toxicity. So the nurse needs to look for the response of the patient when administered with beta blockers and along with these drugs. So some to produce the full effect of the beta blockers, and us must know not to crush the medicine, especially the sustained release tablets. And it is recommended that beta blockers must not be stopped abruptly, because when long-term use of beta blockers makes the production of beta-2 receptors, more and more beta-2 receptor sites are produced. So they can cause withdrawal symptoms if they're continued abruptly. So nurse must know that the dose of the patient is tapered down by the physician and not directly stopped. Also, when administering topical beta blockers like timolol, like we use in glaucoma, it can cause systemic, it's written hypotension. Yes, it's correct. It can cause systemic hypotension since it can get absorbed through our flow. So nurse must instruct the patient to press the inner canthus of the eye so that the drug is not absorbed beyond the eye. So these are these are mostly how the nurse plays a role in the positive and less negative effect on the absorption and distribution of beta blockers, how the patient responds, and how the beta blockers produce actions. So no doubt there is a huge role nurses play while in the treatment with beta blockers. These are the references that I've used, various studies from various platforms. So this was my presentation on beta blockers. Thank you.